You ask about family history. This person is feeling sad, or this person could have said, I am hearing voices. Do you want to ask, does anyone in your family have a mental health disorder? Oh yeah, my mom's schizophrenic, or my sister has bipolar. So it kind of gives you some insight as to what may be presenting to you today. Or it could be no. You ask them for a personal evaluation of themselves. You want to see what their thought about self is, their strengths, their hobbies. What areas of pride do they have? Is this the person who's going to say to you, I'm not worth anything? I don't even know why I keep living. Or is this the person who says to you, I'm a mother, I have to care for my children. I work as a teacher. My children look forward to me coming to school every day. So you want to get a good sense of self and their sense of self-worth. So when you get into the field of practice, you have to learn how to intertwine both your psych assessment into your medical assessment. As you ask some of your questions, you're going to have to learn how to pull these things out of your patients. Because while this patient may have presented for a stomachache or some somatic symptom, and you notice that they have feelings of sadness or anxiousness, then you also have to incorporate this into your questions. You want to ask about culture, religion, past psychiatric history. Is this the patient who's going to say to you, well, just last week I was in IOL because I had a manic episode, or I tried to commit suicide? So you want some past history regarding their psychiatric state as well. You ask about their medical history. Is this someone with stage 4 cancer? Would that give you some better insight as to why they are probably feeling sad or depressed? Ask about their sleep patterns. Sleep is pretty important. This is a question I ask all my patients every single time we interact. How are you sleeping? And very often, when you're sleeping well, things are going well. I mean, just think of yourself. But for myself, I can say for certain, if there's something happening the next day, I don't sleep because I feel somewhat anxious about it. If I am worried about something, I don't get that much sleep because my mind is not at rest. I'm thinking about it all the time. So this is why you want to see, how are your patients sleeping? Are they telling you, I'm not sleeping at all, I haven't slept in the last 2 or 3 days? Are they telling you, I'm sleeping just fine? So you want some information about their sleep. You want to ask about substances. Are they using any substances? Because what do we know about substances? What do we know about substances and mood?
It can affect your mood.
No doubt. And they're depressants. It impairs judgment. I mean, have you ever taken a drink at some point or another? All of a sudden you're telling sad stories, you're crying. Is this person really just under the influence of alcohol, or are they sad? So you want to ask about any substance use. Did they just smoke some marijuana and now they're having psychotic features? So you want to ask, did you smoke or drink anything recently? So these are very, very important questions to ask. I must say, it is the weirdest thing talking to a screen of names, but I guess I'll get used to it. So you want to do your mental status examination. And this is when you're assessing your patient, not solely by the questions you're asking, but from you walk into the room, you start looking at their appearance. What are some things you could see that could set up red flags, like, hey, there's probably something going on here? Their posture. What about their posture, Julie?
If they're like, you know, slumped over or head down, you know, they might not meet your eye contact.
Yes. Is this a patient sitting like this in the room? You walk in, how are you doing? Oh, I'm feeling well. I'm so happy right now. thing you're doing, you're looking at their parents. Their parents is telling you something else. Someone said unkempt. Totally. Is this person odorous, disheveled? Are they dirty? Look at their behaviors. Are they restless? Scars on their bodies, there could be some cutting behaviors. So as you're talking, you're listening, but you're also looking. You're looking for those objective signs. You're also going to examine their speech. Is it slowed? Is there an absence of speech? Is there pressured speech? Are they talking a mile a minute and telling everything you need to know that you can't get a word in? So you have to pay attention to not just how they look, but also their speech. Is their speech, you're asking them about one thing, or are they going off in tangents? Are they talking about everything else but what you're asking them? Is their speech disorganized? And this will give some insight into their thought processes. Are they having any kind of ideations, such as suicidal ideations? You can make sure you ask those questions. Are you thinking of suicide? Are you having any thoughts of hurting anyone else? Are you at all hearing or seeing things that other people are not hearing and seeing? This is where you'll get some information about any obsessions they're having, any phobias they're having, any compulsions. So this is where you ask your questions and you assess their thought processes as well as the content of their thoughts. Someone mentioned their posture. Along with the posture, you're going to look at their affect. Does anyone know what affect is? So this is your affect. It's your outward expression of your emotions. So it could be said that a patient has flat affect. That means it's just blah, it's just dull. It's like no emotions on their face at all. No emotions on their face at all. They just like sit there and their face is like they're telling you they're happy, but no smile, no joy, no nothing on their face. Their affect could be appropriate. They're laughing when they need to. They're smiling when they need to. They're showing signs of sadness when they need to. So that's an appropriate affect, which is what most people have. They could also have a restricted or limited affect, which means is it bad to have a flat affect? It deviates from the norm, because if you're looking at me and I'm talking to you and something excites me, I will smile. Something is sad, I wouldn't be smiling because that would be inappropriate affect. But if I'm just here talking to you like, yes, and you're just going to talk to your patients and you're going to just make sure you tell them. And sometimes you can have a lot of fun. Like, is that normal? No. Right. No, it's not. So a flat affect is not normal. A flat affect usually goes hand in hand with some either depressive symptoms, or as we get into schizophrenia, you learn about the lack of emotion, the lack of showing an expression. So a flat affect is not normal. It could be labile. It could be totally inappropriate. It could be with you that, oh, my husband died last week and I can't believe that he died. And you're like, whoa, what's going on with her or him? That would be an inappropriate affect. So your affect is your outward expression of your feeling or your emotion, just the way you show it or you express those feelings. You're going to examine that patient's cognitive thoughts. And those cognitive thoughts include their insight and their judgment. So is this the patient that's telling you, I have a mental illness, I have depression, but I stopped taking my medications because I was feeling better, and now they're coming to tell you that you feel sad? So that tells you right away this patient has some issues with insight, or their judgment is impaired. Is this the patient who just attempted jumping off a bridge or walked out into a line of traffic? So you're looking at their insight, their ability to reason into what's going on, as well as their judgment. Any questions so far? No? You guys still there?
Yes.
Okay, so along with doing your assessments using objective signs and interviewing the patient to get your subjective data, you can also use standardized screening tools. Now, it depends on where you work. Some of you may already work in healthcare where they have standardized screening tools. There's the mini mental status exam. Are you guys familiar with that?
Yes.
Yes. There's the Glasgow Coma scale. There's the PHQ-9. You'll find that used very widely in psychiatry. It is a scale that's used to measure. Does anyone know?
Mood and behavior.
Mood, yes, but what mood specifically? Depression. It's a scale for depression. So it depends on where you work, they'll have different ones. There's also the Beck depression scale, there's a Hamilton depression scale. So you have different ones for depression. You also have the GAD-7, and that's a generalized anxiety disorder. And 7, I'm not sure it has a 7, but it's a GAD-7, and that's a scale for anxiety. So very often you'll see the PHQ-9 or the GAD-7. A lot of people like to use those ones. Like if one of your parents, when you take your kids to like the pediatrician, and they give them that little questionnaire for them to answer as soon as they hit like their teen years, this is probably what they're filling out, the GAD or the PHQ-9. That, because sometimes patients will tell you they're doing okay, everything is perfect, everything is fine, and then they complete the GAD-7 or the PHQ-9 and it comes up that they're severely depressed. And that's because patients, sometimes can't reason through their feelings effectively to express themselves, but given the question, they will choose the answer that best represents their feelings. Is that understood? You want to make sure thank you. You want to make sure you're assessing suicidality. So as you're talking to the patients, don't be afraid to ask, are you having thoughts of suicide? And especially when it relates to like children or adolescents, a lot of people don't like to use the word suicide because it's rumored you're giving them ideas. Now they're going to start thinking about it. You put it into their heads. Absolutely not. It is a necessary question and it's one that should be asked in order to get the information that you need. Ask about their social supports. Like if you ever needed to talk, who do you reach out to? Who's in your corner? Who's your support system? So you want to know this patient's ability to cope with whatever you're going through right now. Is this the patient that tells you, I'm alone, I have no one? Or I live at home, I have my wife, or I have an adult daughter I can reach out to, or I have a therapist I can call whenever I need to. So you want to know what your support systems are. So if they don't have any, you can help them to establish them. So should the patient say, yes, I'm suicidal? Want to look at lethality? Is this patient talking about eating a box of crayons? Or are they talking about shooting themselves in the head with a gun? You want to ask about any plans or intent. Because I can tell you, a patient who is actively suicidal with a plan and an intent is a patient who needs to be in an acute care setting. It mentions DSM-5 mental health diagnosis. So you also, as you assess them, look if they have any diagnosis or a provider will provide them with a diagnosis. Any questions so far? No? So I'm doing a good job explaining. You guys get everything? It's clear? That's good to hear. So the next slide, assessing suicidality, I went over that before. Social supports, lethality, access, plan, intent. Also of importance, has this person ever attempted suicide? Because if this is a patient that's telling you, I'm suicidal, And in addition to saying that, they're saying, I attempted last week. What does that tell you?
They might be looking for help.
They could be looking for help. And also, this patient has the balls. They will probably do it again. So you need to take this patient a little bit more seriously than the patient that tells you, oh, I've been suicidal my whole life. Have you attempted? Oh, no, I'm too chicken to actually do it. You understand the difference that I'm saying? Because I have some patients who every time they come to see me, they're suicidal. Every single time they'll say, I'm suicidal, I'm suicidal, I'm suicidal. But they have never attempted suicide, which is a good factor. And then you have those patients who will tell you they're suicidal, and you look at their history, and they've attempted 2, 3, 4 times before, and this tells you this patient has the propensity to act on those feelings and thoughts. So there's a mnemonic for assessing suicidality. Is the path warm? Ideations, are they having thoughts? Is there any substance use involved? Any alcohol, any drugs? Because as we discussed, alcohol and drugs does what to your judgment?
Impairs judgment.
Totally. Does this person have a purpose for living? Is it someone who is homeless, living on the streets? Is it someone who just lost their job? Or is it someone who is a parent who has kids to take care of? Or is this a person who's telling you, I have to care for my elderly mother? So what is their purpose? Do they have anxiety? Do they have unresolved feelings? Do they have hopelessness? Hopelessness is actually a key symptom to suicidality. You want to know what they have to live for when you ask them. Like, what's the purpose of living? Are they beginning to isolate and withdraw from the people around them? Do they have anger, rage, reckless behavior, which could lead to engaging in suicidal activity? Have they had dramatic mood changes? So are they dealing with depression or anxiety or anything else going on at that time? That is the end of your assessments, the basic concepts. Any questions? Okay. Legal and ethical issues. So when it comes to caring for mental health patients, it is of importance that we mention legal and ethical issues because it's easy to get the lines blurred as it relates to caring for this patient. Because very often one would think that this patient is incapable of making their own decisions. So sometimes someone will take it upon themselves to make decisions for them. And while that is appropriate in some setting, there are appropriate channels to go through in order to do this. So it's important to remember that mental health patients have the same civil rights as any other patient, any other citizen. They still have the right to refuse. They still have the right to make decisions until they are deemed incompetent to do so. As a nurse, you need to understand and protect these patients' rights. So if this is the patient that's telling you, I don't want to do this, not because, and you would have respected it otherwise in a patient who's not on the mental health floor, it doesn't mean you come over to the mental health floor and you don't listen to a lick of what they have to say because they have schizophrenia or they're crazy. It is important to get informed consent from the patient for treatment that's done to them. And usually if patients are not capable of making their own decisions or capable of signing paperwork, very often they have a conservator, either of their person or of their health or something, who is in charge of doing so. And if it is that your facility thinks the patient is not competent enough to make those decisions, then they can reach out to the proper authorities to get plans or something in place to have someone who can make decisions for them. There should be a written plan of care for treatment as you would any other patient. So not because they are crazy means we're gonna just go about our business and do as we please. They're like any other patient. Collaboration is important because very often this patient will have someone who treats them for psychiatry. They'll probably have a therapist. They'll probably have a primary care person. So collaboration is very, very important for continuity of care. So whether you see them on the outpatient or the acute care setting, continuity is very important. They may need interpretive services. Are they Spanish speaking? Or do they speak Polish or some other language you don't understand? It doesn't mean you're just going to forego having it interpreted to them because you're thinking, oh, they won't understand anyway. Absolutely not. You will provide them with the same services as you would any other patient. Very important, your care should be provided with respect, dignity, and non-discriminatory. And you're like, duh, Zoe, we know this kind of stuff. But I can tell you, when you get into the real world, these lines get blurred very easily because these are patients who will most likely get under your skin. This is the patient who will most likely tell you some very alarming things. And you'll be like, are you kidding me? Oh, I hate working with little Johnny because little Johnny tells me the nastiest, all that, especially little Johnny spit on me or little Johnny did this. So these are challenging patients, and that's why it's important for us to remember that we should always treat them with respect, with dignity, and not in a discriminatory fashion. They should be free from harm. So not because you went into little Johnny's room yesterday and he threw something in his nightstand and hit you, means as soon as you walk into the shift this morning, you're going to tell the CNA to strap little Johnny to his bed all day because he's not throwing anything else at me when I walk into his room. They should be free from harm. Like any other patient, they reserve the right to have advanced directives and the least restrictive care. So I mentioned little Johnny throwing things. Applying a restraint for your shift is not appropriate. So the least restrictive, maybe how about trying to remove the things from little Johnny's nightstand so he doesn't have things to hurl across the room? It's important to remember that there are legal ramifications of our actions, and this is where the lines get very blurred as it relates to mental health settings and mental health care. Because sometimes you'll go to work on a floor and it becomes normal behavior for the staff to do things that are not necessarily appropriate. And you have to remember that you are there, the patient, and you are there to advocate for your patients and work for their best interests. So knowing your state laws is pretty important. Does anyone work in a mental health setting now?
I work in a nursing home that has dementia patients with behavioral disturbances and a lot of schizophrenics and schizoaffective people.
Yes. Can you relate at all to anything that I'm saying?
100%. I actually work as a social worker.
Yes.
So I do those PHQ-9s all the time, every day.
Okay. So tort law in the mental health setting. What is a tort? It is a civil wrongdoing. It is a wrongful act against a person or their belongings. It can occur in the healthcare setting, however, particularly in the mental health setting. And that's like what I said. Everybody thinks they need to make decisions for and be in charge of little Johnny. Little Johnny still has his rights. We need to remember that. And it could be for a tort, it could be false imprisonment, assault, which is an attempt to commit battery, intentional act, or battery, which is the unlawful act of contact with another person resulting in bodily injury. So assault could be even the threat of, you're telling little Johnny, oh, you keep it up and I'm going to come in there and put that restraint on you. Those are torts.
What's the legal ramification if we have a patient that has told us that?
I'm not hearing you clearly.
What are the legal ramifications if we have a patient who states that they want to commit suicide? do we have to, what, as far as HIPAA is concerned and getting them the help they need or securing them in a place where they won't hurt
I
them?
am really, I don't know if I'm the only one having a hard time hearing the question.
I'm sorry, I'm going to turn to the chat box.
Yes, thank you. What are the legal ramifications when we have a patient that states, why did it disappear? Is this it? That states they're going to commit suicide. So, if a patient states you're going to commit suicide, even if you know little Johnny comes on the floor every month or every other month saying he's suicidal, you should follow through with due process for every patient that says they are suicidal. So if you're asking about legal ramifications, I'm assuming like you're asking what could happen if it is that you don't follow through with it. Is that your question, Chris? Yes. So patient tells you you're suicidal, so you do your assessment. Do you have a plan? Do you have intent? So you're working on a hospital floor. This is the patient who you probably assign to have a one-to-one sitter. This is the patient who you probably change your room, put them closest to the nursing station so you can observe. If the patient is actually acting on those plans, then this is a patient who will probably be in a more acute care setting. This is a patient who probably need to be transported to IOL or somewhere, or if your hospital floor, wherever you work, has a psych unit where they can be monitored more effectively. And HIPAA as it relates to telling who? So Chris, you're asking about HIPAA as in if the patient tells you, if you can tell anybody else? Okay, so there are limitations. There are some things that you have to keep confidential. But if a patient tells you they have a plan of hurting themselves, hurting anyone else, confidentiality kind of goes out the window there, okay? That is not something you keep between yourself and the patient. Because lo and behold, they told you that little secret, they're going to kill themselves, you come in tomorrow morning and the patient died. So always follow due process when a patient makes mention of having suicidal thoughts, plans. Make sure you follow through on that, okay? Exactly, or worse. There is something called like a Tarasov law, which is to warn, like the patient tells you they have a plan of killing somebody else, but make sure you check with your administrator wherever you work to make sure that you're following through effectively. It has happened to me and I'm not quite sure what to do. A patient tells me she's going to go home and stab her boyfriend. Can I then call the boyfriend and let him know? You have to look at your state laws. So this is where you get other people involved and get direction as to how to follow through, but never take an information as serious as that and sit on it saying, I don't know what to do. Reach out to the next person. You have a supervisor, you have a department head, you have someone who can guide you along with this. Because that day in particular, my patient told me she was going to go home to stab her boyfriend. We had to get in touch with our company lawyer to see how much we could say, if we could reach out, because different states have different laws. Ethical principles, I'm sure you've seen this since you started nursing school. Non-maleficence, duty to avoid harm. Utilitarianism, the right act is the one that produces the greatest good. Beneficence, prevent harm. Justice, be fair. Fidelity, faithful. Veracity, be truthful. And of course, the patient's autonomy. Never ignore the patient's right to exercise their autonomy. And I must say, as a psychiatric provider, sometimes I struggle with that because they want to make decisions that you know it's not in their best interest, but you still have to allow them to be autonomous. Like for instance, I have a patient right now she's taking an antipsychotic, and this is her third time asking me to take her off the antipsychotic. And the 2 previous times that I did as she asked, she totally decompensated, ended up in the hospital, and had to start her treatment all over again in terms of the medication she was on. And this is the third time coming back, and I'm like, do you remember the first time when we took you off? Yeah. How about the second time when I took you off, remember? And she goes, yeah, but I still want to get off. And I was like, oh, I was hoping I could somewhat guide her in the other direction, but she decided against it, and I have to follow through. Because it won't, while she will decompensate, it's not cause harm, so I can respect her autonomy in that respect. She wants off because she's taking a drug. I mean, as we get into the medications, you'll see why patients do not want to take antipsychotics. While it helps with their symptoms, the side effects are a lot, and she's taking a particular drug that requires frequent blood draws, and she's just like, it's taking up too much of my time. Every week I have to go in, and she just doesn't like it. But every time she goes back into the hospital, the frequency of the blood draws becomes even more. So I'm trying to educate her. The longer you stay on it, the less of the blood draws become, but she's not hearing it. That's because they get to a place where they're functioning really well, and they're like, I'm doing well, I don't need this. And that plays into their insight and their judgment. So there are different ways as to how a patient can end up in the hospitalized setting. So I mentioned, so it could be voluntary. So this could be the patient, or some of my patients will tell me, I was in the ER last week, I checked myself in. So this patient is considered competent. They still have their right to refuse treatment, and they maintain all their civil rights. Like sometimes they'll say, yeah, I wasn't feeling quite right. Like I could tell I was going downhill. So you know what, I just checked myself in to get my meds checked and to get stabilized. And it happens more often than not. They will go there of their own mind and make their decision. Or it could be a temporary emergency admission. It could be by family. It could be little Johnny's mother dragging him off to the ER or calling the ambulance saying somebody needs to come get him, something's not right. It could be your primary care physician. You go in for your visit, you're crying hysterically, telling them, I'm having thoughts of killing myself. Next thing you know, there's an ambulance here to pick you up to take you off to a more acute setting. Or it could be your mental health provider, which is the role I function in. I'm a psych nurse practitioner. And like for that patient who told me that day she was going home to kill her boyfriend, she was having homicidal thoughts. So I had to follow through, and it wasn't safe at that time to send her home because she had a plan, and she told me she had intent. So I had to send her off to the hospital. So usually these patients are there for an assessment, usually over 72 hours. I can tell you it happens quite often where they go in because they presented one way, and patients will tell you, oh, when I got there, I told them I wasn't suicidal. I don't like being there. I didn't want to stay there. And they will, it depends on how they present in the acute care setting. They will be sent home. Very often they call back to say, why did you send little Johnny over? Little Johnny is saying this. He's saying, well, this is what little Johnny was telling me. And while it seems like a waste of everybody's time, at least I followed through and did what I needed to do. Yes, and they'll send them back with a no harm letter, because I can't say, you know what, I sent him the last time, or I sent little Johnny over 2 times, and every time he went there, he said he wasn't suicidal, or she got there and said she wasn't homicidal. What if that one time I decided, you know what, he's fake, and I'll send him home. And they go home and act on those thoughts, and they came back and checked my notes and see that he had told me in the visit that he had thoughts of killing himself or killing somebody else. So it's like you never know, so always follow due process. It could be an involuntary admission where it's by the courts. The courts are saying you need to be inpatient, you need an assessment, or someone needs to evaluate you to see what's going on. So it could be by court also. Or it could be a long-term involuntary admission, such as patients that are at CVH, the State Mental Hospital, where they could be sent there by court. Usually sometimes for a couple of years, they're inpatient in the psych setting. Any questions? See, this is why I like to be in the classroom. I can see people's faces. Effective therapeutic communication. So I'm sure you've done therapeutic communication before. And you're like, oh, this is just a revision. I know, I totally miss going in the classroom. I mean, this is a lot more convenient. I'm sitting downstairs, I run upstairs when I want to, but being in the classroom face to face is, I appreciate that more. We've all done therapeutic communication probably since your first nursing class, how to talk to patients, how to lean in, how to ask questions, open-ended, and yada, 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 yada. So this becomes even more important. Well, it's always important, but it is of utmost importance when you interact with mental health patients. Because how you approach the patient will determine how much information you get from the patient. And until I became a psych nurse practitioner, I can tell you I have totally improved my communication skills. Because I have come to realize that you have to learn how to, at all times, professional at all times, check your body language, check your tone, because they feed into or they pick up on the slightest little thing, or they will even infer that that's what your body language is saying. So you just have to be mindful at all times of how you communicate with these patients. Active listening is important. I will follow up with a patient. If it's a regular patient, it's 30 minutes. If it's a new patient, it's in an hour. And I typically open up by saying, hey, what brings you back today? Or how is everything going? And in that first couple of minutes after me asking my opening question, I can probably get everything I need for my appointment. Because they will say, oh, you know, I've been doing really well. My sleep has been fine. I take my med every day. Yeah, I recently started a new job. It's going kind of okay, but nah, I guess I'm gonna hang in there until I find something better. At home, the kids have started school. Things are going really well. I'm not having any suicidal thoughts though. And that thing I told you last time that I used to see things, I don't see things anymore. That's all of that kind of thing stopped. I went to my doctor the other day. So in just allowing the patient to talk, I will get all my information. So while it's important for you to get all your questions in, it is also important to learn how to listen, because a lot of times you'll get answers to your questions just by listening. Ask open-ended questions, because if you ask a yes/no questions, that's the answer you will get. You want to be able to explore and dig deep into what's going on. When did you start feeling depressed? Did something happen prior to you having this feeling? So make sure you ask those open-ended questions, or you will never get enough backstory or back information to get a good picture of your client, or your patient rather. Again, information seeking. If the patient is having delusions, hallucinations, you want to make sure you're reorienting them to the reality. I know you say you saw something on the wall over there, you saw a shadow in the corner, but when I look over there, I don't see shadows on the wall. So you're not discrediting what you're saying, you're just sharing with them what your reality is, or what the reality is. It's very important to restate. So after you listen to everything that patient has said, like I say in my visits, I'll say, so if I understand clearly, you're sharing that you're having problems with depression, and you're feeling depressed because you lost your job 2 weeks ago, or because you got in a fight this morning. So I always restate in order to clarify. And then I can understand why you're feeling depressed. You validate their feelings. I can also see that while you're talking, your legs are shaking. Are you feeling a bit anxious as you sit here talking to me today? Oh yes, along with feeling depression, I've been anxious. So you state your observations. Can you tell me why you may be feeling anxious? I'm feeling anxious because now that I've lost my job, I don't have money to pay my bills. So you explore your observations as well, or the statements that the patient making. So those would be effective communication styles. It's very important to seek the patient's description of their feelings. Patients will come to me and say, I'm depressed. Can you tell me what depression looks like. Can you tell me what it means to be depressed? Because I have my idea what depression is. It doesn't mean that your idea is the same as mine. Patients will tell me I'm depressed, and they'll just say, "Oh, I've just been sad." Okay. Any other thing that's going on that tells you you're depressed? No, just feeling a little down. Well, the next patient will tell me I'm depressed. I'm not eating, I'm not sleeping, I have no motivation, I haven't showered in weeks. So you want to get their description of their feelings, not just the label. You want to be able to empathize with your patients and acknowledge their feelings, as I mentioned prior. You're also looking for patterns and themes. Have you ever felt depressed at any other point in your life? Sometimes they'll come out and tell you, "Oh, I feel sad and depressed every time." I heard it twice today. Every time it gets to this time of the year, because we're going to have a time change, I think. Is it Sunday? Every time it gets to this time of the year, I know the time is going to change. It's going to get darker earlier. I start feeling sad. So that gives me an idea of patterns and themes, and that's leading me to think this patient may have, or sometimes I tell you I have a seasonal affective disorder. So throughout those winter months, they have more increased depressive symptoms. Help them to reframe their thoughts and focus if it is that they're going off on tangents or circumstantial speech. Reinforce healthy behaviors. Should the patient say to you, "So because I've been feeling sad for the past week, I made sure I went back into the gym, I've been exercising every day." Oh, that's a very healthy choice. That's very good you've made that choice. So that's a step in the right direction. So you want to make sure you're reinforcing those healthy behaviors. You want to avoid self-disclosures. While you yourself might have lost your job at some point in your life and you too feel sad, it's okay to say to the patient, I understand the way you feel. It's probably less okay to say to the patient, "Well, you know, at one point in my life, I lost my job too. And when I lost my job," and just try to keep it as professional as possible. Sometimes it will be appropriate to disclose some personal information, but try to make sure it's nothing that can be used against you. It's nothing that you're telling the patient in secrecy, because very often it will come back to haunt you if that's what the information was. Do not make assumptions. While the patient is sitting there shaking her leg and I may think it looks like anxiety, I will not say to the patient, "You look anxious." Always ask the patient to state their feelings. And I mentioned prior the importance of sitting in silence. And this is when my patient comes in initially and I ask that opening question. Silence speaks volumes. I'm sure you've heard that statement before. Sometimes it just needs someone to listen. Be sure to set boundaries. So depending on what mental illness the patient has been afflicted with, some of these patients can be inappropriately friendly. This is the patient who may want to hug. While it's appropriate to hug your patient at times, you should reason through the appropriateness of it. Did this patient just lose a child? Are they sobbing uncontrollably and you're giving them an embrace around the shoulders? Is this a male patient who walks up to you, wants to hug you from the front? Is this the patient who wants to call you by your nickname? So make sure you are keen to boundaries and make sure you're adhering to them, because those lines can get blurred very easily too. As you establish rapport with these patients and they become familiar, if you're working in a long-term care setting where you get to know them, they get to know you. Next thing you know, you're bringing them little treats to work or little extra things. Just make sure you're setting professional boundaries with your patients. Any questions? Not yet. So we spoke about effective communication. Ineffective communication will be all the opposites of what I just said. Giving false reassurances. What could that be? What's a false reassurance? Everything will be okay. We will take care of you. By the time you leave here, you will not be depressed at all anymore. Absolutely not. Well, that is your goal. You can't tell that to a patient because that's false reassurance. You don't know if the med's going to work. You don't know how they're going to work through that stressor. So you can't tell them something's going to be that isn't, that you're not sure that it is. Not listening. So you walk into the patient's room. So, little Johnny, what happened? What brings you here today? Well, I've been feeling okay. And what time did you get up this morning? So, instead of giving the patient time to talk, you are on a time crunch. You're like, you know what? I only have 10 minutes in here, and he's gonna blab and blab and blab and blab. I need to get this done. And that will happen sometimes. You go to assess this patient, and they just want to tell you about their entire life story. And this is where you try to redirect them. So try to find the proper opening. Sometimes I only have 30 minutes and they want to talk and talk and talk, and I'm like, I need to get these questions in. So as soon as I find an opening, I just sneak my little question in and try to direct them. Not cutting them off, I try to sneak it, like find an opening to ask the question, and you can get them back on track, and hopefully you can get your assessment done. Don't minimize the patient's problems. And whenever I think about minimizing the patient problems, I remember one day one of my patients, she came into her visit and she was very distressed. This is a woman in her 30s, like very, very distressed. And I'm like, I became concerned. She was feeling depressed, she was anxious, she was hyperventilating in the office. So when I asked what the precipitating event was, she told me she was upset because her baby father's girlfriend was calling her, and then she called back the baby father's girlfriend, and they were having some phone conversations back and forth. You calling my phone and I'm calling your phone, and stop calling my phone. I'm like, are you kidding me? But of course, I couldn't at all let her see that, are you kidding me? Look on my face. I had to listen intently because this was her stressor. I couldn't minimize, like, I couldn't say, are you kidding me? Calling back and forth like your teenage girls, I couldn't say that. This is her stressor. And this is what is important to her at this time. So I had to validate her feelings. I can understand why that would make you upset. I can see why you feel the way you feel. So never minimize the patient's problems. And be careful about giving advice. Make sure the advice you're giving is empirical data, not something grandma told you that you think may work, or something you watched on YouTube or read on Google. So make sure whatever advice you're giving, it's tried and true and it's appropriate. Try not to feed into the patient's hallucinations. Like I said, you try to reorient them to reality. You try to redirect your thoughts. Changing the subject, it's something that can tick a patient off in a second. And that is why I say I try to find an appropriate opening. Oh, you asked me a question, but you can't let me talk, so I can't talk now? So, oh, you just want me to answer your question, so I have nothing to say here? It can go south really quick. Belittling the patient's feelings plays into minimizing their problems. Never criticize or be judgmental. You're there for the patient to advocate and listen to and speak to your patient, not to condemn them or to belittle them. And again, it points to self-disclosures, which I mentioned before. At all costs, try to avoid self-disclosures. Sometimes it will be appropriate, sometimes it will be even necessary. But make sure it's done in the right manner and in the right setting. And I'm going to take a break here before I head into defense mechanisms. Any questions? Nope, so we will break for, let me see, we can do like 10 minutes here. We will come back at 6:10. Okay.